With you in 1 second. Are we up?
You were up and then it just, everything cut out. But you're back up. You're back up.
Instagram?
You're back up and everything.
Okay, so hope you're all logging on. Looks like we had a little technical glitch there for some reason where everything shut off. So welcome back. This is Fertility Fact or Fiction, the Euro edition, so that our European fans and followers can watch and join on as well. And we're just going to start chatting about this article. We usually spend about 10 or 15 minutes just chatting about the article, and then we open it up to questions. I'll answer anyone's questions. And most people want to know something scientific. That's great. If you want to know about me, I'm pretty open book, so I'll tell you about me as well. And we'll go from there. I hope all of you got a chance to see the workout video on Instagram. After a long pause in working out, I figured I couldn't tell my patients to work out unless I was doing it with them. So hopefully I'll keep recording all of those, and we'll do maybe a before and after video, or preferably more after, because the before is not pretty. And we'll see how it goes. I'm just hoping we can all do it together. You guys can inspire me and I can inspire you, hopefully a little bit too. I may even drag Tarek into it. We'll be working out together, and I'm sure at some point. Okay, so this article is called Micronized Progesterone plus Dydrosterone versus Micronized Progesterone alone for luteal phase support in frozen thawed cycles, a prospective cohort study. So the interesting thing about this is they compared a oral and vaginal progesterone versus just a vaginal progesterone. And the oral progesterone they used is more commonly referred to as Dufastin in Europe and Asia. We actually don't have access to it here in Canada, but it is commonly used in Europe and Asia. I've seen a lot of our Persian patients on it from Iran, so it's probably available in most of the Middle East as well. So the typical protocol we use here, and just to kind of give you some background, is we went initially from using progesterone in oil to just vaginal, and then we went back to using the progesterone in oil because there was some data that suggested that the progesterone in oil was better. We kept the vaginal progesterone because of the fact that when you're taking progesterone in oil, that's going into your bloodstream, and it's through your bloodstream that it's having its effect. But there's also what we call a paracrine effect of hormones in your body on the uterus. And paracrine means it's actually from hormones that are right next to the organ that's being affected. So some of your progesterone goes into your bloodstream, but some of it needs to actually go into the uterus more directly. And because your ovary is close to the uterus, even from a blood flow perspective, that is happening. But when you're doing it through IVF, you actually need to deliver the progesterone to the uterus. So we use both to get a better and more accurate mimic of what your body would naturally do. So we're giving you vaginal progesterone and we're giving you progesterone in oil. This study took it to a different stage or a different level and said, what if we give it to you orally versus, orally with vaginal versus vaginal alone to see if that makes a difference. So the interesting thing about this study is this is actually the first study I've ever seen from Vietnam in infertility, so that was kind of cool. It's from Ho Chi Minh and a special hospital called My Duc, D-U-C. I hope I'm pronouncing that correctly if you're from Vietnam. So they studied 1,364 women undergoing IVF with a frozen embryo transfer. They did luteal support from the time that you were getting an endometrial thickness of 8 millimeters or more. And they started you on either 400 milligrams of what's prometrium, which is the micronized progesterone, twice daily, which is close to what we do. We do 200 milligrams 3 times daily. And then they compared that to a group that did the same thing, but also used 10 milligrams twice daily of the Dufastin or dydrosterone. So basically one group getting prometrium 400 milligrams twice a day, vaginally, the other group getting the same thing plus the dydrosterone 10 milligrams twice a day orally. And what they were looking for was the live birth, and then they looked at a whole bunch of secondary outcomes. So I don't have graphs for you today, just because we're a little rushed in getting this all together, but we will review the numbers for you. So they actually had 3,614 women that were screened. 1,721 met eligibility criteria. And they said 1,364 provided consent that were acceptable. 73 of them wanted 3 embryos transferred, so they were out. They were only taking patients that did 1 or 2 embryos. And 284 of them had other regimens of support, so they couldn't be included because maybe they were on oil or another oral agent or something like that. So they ended up with that 1,364 number. Main outcome was live birth. They looked at miscarriage, thickness, embryo days, embryo quality, all sorts of other things that they were checking out. So, and then they had a lot of confounding variables that they screened for, like your age, your body mass index, the fertility cause, whether it was male factor, female factor, endo, and so on. They looked at number of IVF attempts and so on. So all of this was kind of important. So the first bit is just a demographic table. Their table 1 is a demographic table. And that demographic table is interesting because the average age in years of the patients was 31 years old in both groups. So the progesterone vaginal only and the 2 progesterones oral and vaginal, they were both 31. So that's a pretty young group. It doesn't really necessarily apply to what we commonly see here, where our average age is going to be much higher, more like 36, 37. Number 2, the body mass index is what anyone here would consider positively thin. So 20.9 in the 2 progesterone group, 21.4 in the single progesterone group. So very, very low BMI, which is probably mainly cultural. And so that's important to note because you have to make sure that the groups are comparable. So do you fit into that same picture? You may not. Does the study apply to you? It may not. It's entirely possible that your body mass index could play a role, and maybe the data from this study doesn't represent how it's going to respond in you. Most of the patients had primary infertility, about 2/3. 1/3 had secondary infertility. The vast majority of them, over 96%, were on their first IVF cycle, 93.8% in the group that was doing single progesterone. Most of them, again, were on their first embryo transfer, and the majority from both groups had male factor. Next largest group was probably tubal factor, some unexplained, and so on, ovulation disorder. So reasonably representative in terms of the reasons for infertility, but in regards to body mass index and age, definitely both significantly lower than what we see. So age was lower, body mass index was lower. Okay, so what were the things that were significant that they found? So first of all, the endometrial thickness was a tiny bit thinner in the women that had both progesterones versus 1. Now the difference was only about 0.3 millimeters, so it's 10.84 in the 2 progesterone group, and it was 11.1 in the 1 progesterone group. Why is this important? Some of you might be thinking, I thought thicker was better. Thicker is not better. After you start your progesterone, your lining should be compressing and shrinking. And so this is really important that you actually see a thinner lining than you did before. So maybe this slight bit of extra compaction is actually part of the reason that the 2 progesterones are potentially beneficial. They didn't see any difference in terms of length of the luteal phase. They didn't see any significant differences in terms of progesterone values. And in just the straight head-to-head comparison, they actually didn't see any differences that were significant in live birth either. Number of embryos transferred, same. Number of good embryos, same. All of that stuff was the same. When they got down to miscarriage rates, for ectopic pregnancy, they saw no difference. There were 6 in one group, 5 in the other, so that was the same. But the miscarriage that occurred at less than 12 weeks was almost exactly half in the group that got both progesterones versus the group that got 1. So there were 25 cases out of 732 in the oral and vaginal progesterone group versus 6.6% or 42 cases in the vaginal only progesterone group. So 3.4% if you had 2 progesterones, 6.6% if you only had 1. And that was highly significant. So that's the first really important finding from the study was that the miscarriage rate was much lower in the group that had both progesterones than in the one that had only one. And that's almost a 50% reduction. So it is very significant. The other significant finding, interesting, there was a higher rate of gestational diabetes in the group that had the progesterone. No explanation for that, but it was about 3% higher. Is that significant? Who knows? I mean, normally we can control gestational diabetes really well, but there was a slightly higher incidence. In general, this population is very thin. They're probably reasonably low risk. The rates were around 8 to 11%, so not very high. They looked at all sorts of other things like preterm delivery, low birth weight, growth abnormalities, fetal anomalies. There was no difference between the two groups in any of those. Okay, so then the next thing they looked at, which was really important, was what about when we analyze this looking at all of the confounding variables? So let's plug in all of the factors like age and body mass index and your anti-Müllerian hormone level, duration of infertility, etc. And the cause of infertility. They even put in the serum progesterone levels, the number of embryos transferred, and stage of the embryo. So they really did a good job of controlling for as many factors as they could. What did they find? So if you had both progesterones versus the single, so the oral and the vaginal versus the single, you actually had a 30% increase in your chance of having a live birth. So that's huge. That is a big, big difference. So if you're on simply vaginal, your rate was going to be 30% less, or if you're on both, 30% more, by taking both progesterones, the oral and the vaginal. They also looked at all of the other factors, and aside from a small blip with more people having secondary infertility in the group that had live birth, with the group that had only one progesterone, that was the only other thing that was significant, which really is not part of what we're concerned about here. So essentially when they looked at that, they said, okay, so your miscarriage rate's lower, your live birth rate is higher. They then did a subgroup analysis looking at your progesterone level in regards to what was happening in terms of live births and ongoing pregnancy and so on, and found that there actually was no difference even when they analyzed it by your progesterone level. The only group that showed anything, again, was that miscarriage rate ended up being much, much less if you were in the double progesterone group compared to the single progesterone group. And that was actually quite important. So especially for the ones that had lower progesterone levels, they were in the lowest level of progesterone, there was a statistically significant increase in not miscarrying. In other words, you went on to live birth if you were taking both progesterones versus one, even when your progesterone level was lower. So overall, what they say from this is it does look like taking a vaginal and an oral progesterone is better than just taking a single vaginal progesterone. This kind of echoes what we like or do, because we use the progesterone in oil, which admittedly is horrible to give to people because it's quite uncomfortable, and we use the vaginal progesterone at the same time. So I think the idea behind getting some into your bloodstream and getting some directly delivered to the uterus makes a lot of sense, because only directing it to the uterus is not really mimicking what your normal biology would do, where in your normal habits or your normal bodily function, the release of the egg causes both paracrine and endocrine effects, or what we call autocrine. So essentially what's going to happen is when you release an egg, progesterone will go into your bloodstream, but because your ovary is very close to your uterus, some of that blood flow will directly pick up the progesterone and deliver it to the uterus. That's not happening when you go vaginal as much, because you're getting less absorbed into your bloodstream, a lot more absorbed directly into your uterus. So the fact or fiction here is, can two progesterones help when one is not enough? Yes. It does look like two routes of progesterone are better than one. Again, here in North America, we don't have access to digosterone, but we do use the progesterone in oil as a surrogate or a supplement. it may be that if this ever becomes available, it would be something worthy of considering. And when we have patients that are allergic to the progesterone in oil, which happens every once in a while, we actually do this by putting them on oral permetrium and vaginal, because you can take oral permetrium, the micronized progesterone. And we're trying to mimic this same idea that we're getting some into the bloodstream, some into the vagina. So I hope you've enjoyed that part of the show. It'll be on our YouTube channel. Make sure you like, comment, subscribe. And if you're watching us on Twitter or Instagram or Facebook, make sure you follow us for Dr. Victory or Victory Reproductive Care. We'd love to have any questions that you have or any comments, and make sure you post them for everyone to see. So now we're going to take your questions live, and we'll start answering. I'm assuming people have been asking, so fire away.
Yeah, you have questions for sure. You have questions for sure. All right, we'll start on Instagram.
Yeah.
Thanks from the Netherlands. So.
Hello, Netherlands. This is going to be like hello to Europe all day long.
Yeah, we should have made that requirement. Say where you're from. Let's see.
For sure.
J Victory 0 asks, who is your favorite of your children?
Jenna, I love all my children, so don't be a troublesome little kid.
And then she asks, why is it Jenna?
Go on, next question.
Happy Sunday, Dr. Victory. What are your thoughts on the Receptiva DX test, BCL6?
Yeah.
Is it worth doing, and do you offer this?
No, so it's not worth doing. So the idea behind Receptiva is to look for endometriosis and whether or not the lining of your uterus is ready. It has never been proven to be beneficial. The studies for it do not support its use. It's no better than doing the ERA test, which is totally useless. There's another study coming out I was just sharing with one of my patients, which again shows that the ERA test is not useful. So ignore all of that stuff. Do not spend the money on Receptiva. A good protocol should eliminate the need for any of these things. So don't bother with any of that. It's not going to help you. If you want to know if you have endometriosis, there is only one test right now available for endo, and that test is a test called laparoscopy. So it's not a test. You need surgery. You got to go in, look around, see the endo, actually biopsy it, send it to pathology, have them tell you that they see stroma or glands from the endometrium there, and then you know that you actually have endometriosis. Without that, you don't know. You might have it, you might not.
Hi, Dr. V. Can you tell how many eggs are left in the reserve after IVF?
So you can't tell, but you can have an idea from your hormones. So remember that just because you do IVF and you take out, let's say, 10 eggs, does not mean you now have no eggs left. You, at any given time, most women will have literally tens of thousands of eggs there. So even when we take out 20 or 30 or even more, we're not really putting a dent in what's left there. So if your AMH is high, your FSH is reasonable, and your antral follicle count is good, then you're still going to have lots of eggs even after an IVF retrieval. If you have very few eggs left, then removing a few at the time of IVF is still not going to impact anything. You started with few, you're still going to have few, but it's not so finite a number that, for example, if we take out 3, you're not going to have any left and you're suddenly in menopause. Each month you'll still produce a few until you actually stop producing any eggs. And that's typically not something that happens immediately after an IVF cycle. It can take months or even years for that to come about. Great question, though. Thanks for asking.
Thank you for doing the show on a Sunday. This is great. When do you recommend starting HGH during stims? At the time as gonal menopause or earlier? 38 years old, using HGH to try and help egg quality.
So HGH is human growth hormone. It's a product produced by Serono. It's called Sizin. That's their product name. So the studies in the past, there was one study several years ago which supported the use of Sizin for improving live birth. And then they actually had a randomized controlled trial last year which showed that it didn't help anything. So I never got on board with it because it's super expensive and it's never been proven to be helpful. If you're using it, most people use it kind of leading up to the stim and through the stim, but I just find it really expensive and not really helpful, and the studies, the data for that supports that. So maybe I'll review that. That would be a good topic to do. Maybe we'll do that for next week. I'll pull up all the studies on it. There was a Cochrane meta-analysis on it years ago, and that showed that it was beneficial. But then subsequently there was this randomized controlled trial, which we didn't have before, which said it wasn't. So we don't use it here.
Thank you for the weekend live. Finally able to watch your live video from Europe. Virtual
cool.
hug.
Virtual hug. I hope my wife didn't see that.
No. I don't think so.
I still love you, Wendy.
Hello, doctor. Last week I learned that my first FET PGT euploid failed. I'm 34, no history of endo. I did a medicated cycle, 6 milligrams of estradiol, which has increased to 8 because I was forming follicles. Then cetrodide was added in, also on progesterone in oil, 1 mil, which was up to 1.5 once daily because levels on the day of transfer were at 15 and the doctor wanted 20 or higher.
Sure.
Taking all of your recommendation supplements, melatonin, baby aspirin, fish oil, iron, CoQ10, prenatal, acupuncture, athletic, normal BMI.
Wow.
My doctor suggests we try a natural cycle with the next period. My baseline is tomorrow. What are your thoughts? Would you recommend any testing? I also want the hidden C test, but my doctor hasn't heard of it. I only have 3 PGT euploids left.
Sure.
I have a balanced transaction, took 4 retrievals. I'm scared of another failure.
Wow.
How do I best advocate for myself?
Okay, so that's a lot of stuff there. So number one, we use letrozole, and I would recommend you use letrozole. We don't use very much estrogen at all. In fact, these days with our letrozole protocol, we require almost no estrogen. Rarely we need just a little bit. So I approve of the idea of going with a natural cycle. That's a very reasonable approach for you. The less estrogen you're taking, the better. So it sounds like you were on quite a lot there, and that may be detrimental. On top of your progesterone in oil, like we just talked about, make sure you're also getting a vaginal progesterone and your progesterone in oil. So that's also important. I'm really glad to hear you're doing all the supplements. Make sure your vitamin D is appropriate. Make sure your melatonin is good. You don't actually need your doctor for the hidden C. You can order that test yourself. So it's www.fertilysys, fertilysys.com. You can just order the test. They ship it directly to you. You do it and they'll send you the answer. Once you get it, you can go to your doctor and say, hey, I tested positive for this. I want treatment. And if your doctor's not willing to do that, you probably need a new doctor. Those are the reasonable first steps. Keep in mind that it does, in general, take 2 or 3 euploid embryos to achieve 1 live birth. So the study from Richard Scott and his group going back a few months ago that we reviewed on the show demonstrated that if you have 3 euploid embryos, you have a 95.2% chance of success. So it doesn't always work on the first try, even when the embryo is normal. I certainly appreciate the fact that with a balanced translocation, you have had to try many times just to get those 4, and they're certainly precious. I don't want you wasting any, but I do know that it can take more than 1 try. Having said that, I would look at using letrozole. I would definitely use 2 routes of progesterone, the vaginal and the injectable. At least that's what we do. And then on top of that, make sure that your vitamin levels, your melatonin, all of that are in place as well. It sounds like you're doing everything else appropriately. I like the hidden C test. To me, it makes a lot of sense. But you know what? I like the ERA test when it first came out, and I got proven wrong on that one, obviously, because now I hate it. So, right now the hidden C makes sense to me because they're actually detecting bacterial content in the uterus. Do you have to use it? No. So just last week, we reviewed the fact that if you take antibiotics, it improves your outcomes when you have endometritis. So there's nothing to say you can't just take antibiotics and then a probiotic and see if that improves things. The problem is some of the bacteria that the hidden C looks for treat bacteria that require certain antibiotics, and other ones have other antibiotics. And the one we typically would give patients, what we use is azithromycin, will not treat everything. So if you have, for example, Gardnerella, which they frequently look for, or trichomonas, or anything like that in the lining of your uterus, for that you're going to require a flagell or clindamycin. If you have something like a chlamydia species in there, for that you actually need the azithromycin, and they don't work on the same bacteria. Azithromycin will not treat Gardnerella, and flagell will not treat chlamydia. So unless you're taking multiple antibiotics, you may not get full coverage. So hopefully that'll help you. And advocating for yourself is easy. You're in charge. No physician can tell you what to do. So you just have to say, this is what we're doing for my cycle. And if they don't want to listen to you, take your embryos elsewhere where you find someone that will, for sure.
Do you have a protocol preference for IVF cycles where, due to the egg quality low, no day 5 embryo develop? Have heard about androgen priming cycles. What are your thoughts?
So guys, there's a huge difference between your egg quality or embryo quality and your IVF stimulation protocol. Stimulation protocols have never been demonstrated to have any difference in the quality of the embryos, regardless of which attempt or approach you use. The number of eggs and embryos may differ based on testosterone priming, estrogen priming, microdose flare, Clomid, letrozole, like there's all these different techniques, the human growth hormone we talked about earlier, but none of these have to do with the quality of the embryos that you are producing. So lots of people say, I'm taking DHEA to improve my embryo quality. There's 0 studies anywhere that shows that DHEA improves your embryo quality. Same thing with the human growth hormone, same thing with all of those other protocol approaches. None of those will improve your embryo quality. They may, and I emphasize may, help you make more eggs than you would on, for example, a long GnRH protocol or even an antagonist protocol, but they're not going to necessarily affect the quality. So what should you do if your embryos aren't making it to day 5? Well, you really only have 2 choices. One is put them in on day 3. And 2 is actually find donor eggs, because if you're not getting to day 5, there is no way to force your embryos to get to day 5. Sure, all of the supplements and dieting and healthy steps and exercise, smoking, drinking, drug use, like when you address all of those, take all the supplements we recommend, all of those can really help you. But are they going to make a night and day difference? Probably not. So you have to be realistic about your expectations. And if the embryo quality is so bad, persistently you're not getting to day 5, you either have to go with a day 3 or you actually have to choose to use donor eggs. Yeah.
Multiple fibroids outside of the uterus. One IUI failed. Need to remove fibroid first, or we can try a second time? Or do you recommend IVF? What is the wait period for IVF? Thanks.
So if you have multiple fibroids and they're outside the uterus and they're not distorting the inside of the uterus, you don't necessarily need them removed. I find it seems to be beneficial, and there are studies that support that if they're over 4 centimeters, but not everybody will agree with that. In terms of can you try IUI again, for sure. Is IVF better? IVF is always better than IUI. Statistically speaking, it doesn't necessarily mean you have to, but if you're looking to improve your success rates, it's definitely an easy way to improve your success rates for sure. If you're doing IUI and you have, IVF and you have a lot of fibroids, I usually recommend you remove your fibroids. We typically will do it in a staged fashion. So you want to do your IVF, make your embryos, freeze your embryos, remove all the fibroids, and then do your transfer. Because if you do it ahead of time, the one thing that can happen is that you have eaten up months of time waiting for your uterus to recover, which you could have used in that interval between making your embryos, freezing them, and doing the transfer. So that makes a bit more sense to me, but it's totally up to you, and you're certainly not going to be harmed by going the other way. It's reasonable to do either one.
Unexplained infertility, 3 fails, 1 fresh and 2 frozen. What's
Okay.
next? Biopsy of uterus conducted and no immune issues found. I believe 10 days after transfer, even though on injectable progesterone.
Wow. So I'm sorry. Unexplained infertility is tough. I would look at several factors. So we would typically start with a detailed look at the sperm, look at your genetics, do that hidden C test from Fertility if you haven't done it already, which is not the same as an endometrial biopsy. It is different entirely. Make sure your vitamin levels are appropriate. Make sure they have a good protocol for you. If you're only using injectable, use injectable and vaginal progesterone. So there's a lot of stuff. You probably need to talk with me or someone else and make sure that they're doing all of the right steps for you, because unless you know that you've got the full kind of picture, you just don't know if you're getting all the right treatment or not. Yeah.
Is there any way to reduce the risk of early miscarriage in a couple with a healthy lifestyle? No smoking, no drinking, no history of drug use, no high BMI. I'm 33 years old. He's 38, trying to conceive since 2019.
So if you've had recurrent pregnancy losses, you need an evaluation. So there are factors that can be hidden in your genetics, in your uterus, in infections, in the sperm DNA fragmentation, which you wouldn't even know about despite doing all those healthy things. So if you're having recurrent or repetitive miscarriages, that's something that needs evaluation by a fertility specialist. If you have not had that, you just want to avoid miscarriages, sounds like you're doing all the right things. Make sure you're on vitamin D. That is associated with maintenance of a pregnancy. You want your folic acid. That's also really important. Again, you're doing all of the other things. So those are the main ones. Iron probably has an impact as well. So that's one of the ones we started targeting now also. So yeah, those are the kinds of things you can do to improve your outcomes.
What is better when trying to conceive? Having sex a couple of times per day during the days the girl is ovulating, or retaining the semen a couple of days and ejaculate when she ovulates? What is the best for having highest chances of healthy baby?
So it's every 2 days throughout the whole month, and once a day, every day, for a couple of days around the time of your ovulation. So for example, if you're using an ovulation predictor kit, you should have sex the day it's positive, the next day, and the day after that in a row, but only once a day. If you're having sex multiple times a day, more power to you. I'm sure it's lots of fun and it's great exercise, but you're firing blanks after the second try. So that's useless, and you're just depleting your sperm count subsequently. So don't bother with doing it multiple times per day. You just want it every other day, the whole month, and then every day for about 3 days, maximum 4, around the time of ovulation. And that's just once a day, each of those times. Sorry guys, or ladies, if you were hoping for more.
Can you briefly explain what an ERA...
Tarek's laughing.
Can you briefly explain what an ERA biopsy is?
Yeah.
And do you recommend it for all your patients?
So I don't recommend ERA for anybody except for patients whose lining never thickens, having nothing to do with the timing. So the ERA stands for endometrial receptivity array. I think we now have 3 videos. I think we do, right? I think we have 3 videos. We have 3 videos all demonstrating how much the ERA does not work. So let me emphasize that again. The ERA is useless. It does not work. So the endometrial receptivity array is a test designed to tell you 2 things. Is your lining receptive, meaning protein and enzyme-wise ready for the implantation of an embryo? And if it isn't, is it pre-receptive, meaning you need a longer exposure to progesterone, or is it post-receptive, meaning you're too exposed to progesterone? You need a shorter window of progesterone exposure. So they came out with this, they made a big splash, it went kind of worldwide, the company grew, they spun it off for, I don't know, $200–300 million of profit, and then everybody started realizing it doesn't work. Their own study, published in Fertility and Sterility, demonstrates that it's useless. So, and that's their own study. So the endometrial receptivity array is designed to take a biopsy, analyze with a microchip, literally a microchip, how high the levels of various proteins are, and then decide based on those protein levels whether or not the lining of your uterus is ready to accept an embryo or not. The problem with it is this idea that you have a very narrow window of implantation, they claim it's 6 hours, is just false. There are other studies we've reviewed on the show. We have a video called "Is 6 or 7 days of progesterone better?" Or day 6 or day 7. Yeah. So not 6 or 7 days of progesterone, it's transferring after 5 days or after 6 days. And in that study, they compared taking day 5 embryos and putting them in after 5 days of progesterone or 6 with no ERA test whatsoever. There is no difference. You can put day 5 embryos in after 6 days of progesterone and get the exact same outcome. So the idea that there's this little 6-hour window is just flat out wrong. It just doesn't exist. So save your money. Don't spend $750 on a test that doesn't work. It's a total scam. Do not bother doing it. It's a waste of time and money. It's only good for patients who do the test when their lining is so thin that you can't get it to thicken and you still want to check to see if it's receptive. So as an example, years ago I had a patient who had a balanced translocation. She had only one genetically normal embryo from her IVF cycle. She wanted to make sure everything was perfect. No matter what we did, we tried everything available. I could not get her lining to thicken. It was only getting to about 3 to 5 millimeters. So we did the ERA test, and the ERA test said, yeah, it's receptive. We transferred it in, and she got pregnant and had a baby. So it's very, very specific. I'm not even sure it's useful in that circumstance, but it's the best I've got. So right now I have another patient who I've literally tried everything, even PRP, and we're having a hard time getting it to work. So in that patient, I've said maybe we should do the ERA test. She's probably the first patient we've done the ERA test in I would say over 2 or 3 years now. Otherwise, I won't do it. It's completely useless. It doesn't work.
Dublin, Ireland says hello.
I love my Irish patients. We have so many patients from Ireland. It's incredible. We got to go start a clinic in Ireland. You know what? We seriously may look at starting a clinic there. I don't think you guys get the kind of care you deserve. So thank you for joining us. Yeah, fire away.
Do you recommend aspirin in IVF for recurrent miscarriage?
Yes.
If so, from transfer of positive tests, I have contradictory advice from consultants and clinics.
No. So aspirin is definitely beneficial in fertility. We have a video on that. If you go to our upload section on our YouTube channel, not popular upload section on our YouTube channel, I think it's about 12 down, 13 down there. It says aspirin and infertility. So it is definitely beneficial. There's no question. There are multiple benefits. It reduces pregnancy complications. It probably increases success rates. Certainly in recurrent pregnancy loss in conjunction with steroids, there is evidence that it works. So we would definitely recommend you consider it there. And you should start it before you ever even get into your cycle.
And because of that, there is a higher incidence of preterm labor, preterm delivery. So by using the aspirin, you're actually reducing the risks of preterm delivery. You're reducing preterm labor risk, and that is huge because the outcomes for the babies that we are creating is as important as the creation of the babies. And we do not want you to get pregnant, but then deliver a baby too early, where now we're dealing with compromised morbidity, mortality, months in the NICU, very high costs, obviously emotional anxiety.
Flow to the area at the time that the embryo is implanted. In order to achieve all of those, the aspirin needs to be in you for days before you get to that stage. So start now. There's zero risk from aspirin, unless you're a smoker, steroid user, history of a stomach ulcer, you're really, really thin, that kind of thing, then sure. Or you have a bleeding disorder. Obviously discuss it with your physician, but anyone telling you to start aspirin after just doesn't understand the whole mechanism. So if you understand it mechanistically, you'll understand that it has to be there ahead of time, not afterwards. Great question. And hello, Ireland. I love Ireland. Dublin and the surrounding is one of the nicest places I've been in Europe.
It's right here if you want to just mention it.
It's right there?
No, other side.
Other side?
Yeah.
It's right there, I think.
That's what it looks like.
Yeah. So that's what the video looks like. So if you click that link, it'll take you there. Make sure you subscribe and comment. We need lots of comments. So comment on our YouTube videos.
Okay.
And share.
Hi, my favorite doctor.
Hello, my favorite patient.
I have low AMH 0.468 micrograms per liter. The doctor told me that
nanograms
per liter.
Yeah.
The doctor told me that my follicles were empty or the egg cells was bad quality. The doctor also found out that I have 6% of mosaicism of chromosomes.
Sure.
Could this be the reason for these bad results? Thank you.
Yeah, I mean, if you yourself are a mosaic, it means some of your cells are genetically normal, some are not. Because your egg cells are derived from your progenitor cells back when you're a fetus, some of them may have been abnormal at that time. So you may have a whole pool of genetically abnormal eggs there, as well as some that are normal. If your AMH is that low, it means you're down to very few eggs. And so depending on how high the level of the mosaicism is, in your case it's low, it's only 6%, then you may end up with some eggs that are normal and some that are not. We do know, and we presented this about 4 weeks ago, that patients that have lower AMH values and produce fewer eggs have a higher number of genetically not normal embryos. So it sounds like there are kind of multiple complications for you there. That doesn't mean it's not possible. It is still possible, but it is harder. So you may require more tries. You may end up requiring a donor. Yeah, I'm sorry. I really am.
Okay. If DNA fragmentation is present in sperm, is TISA-MISA procedure our only option? Are there any negative side effects of either procedure?
So there is some data suggesting that TISA or PISA or MISA can improve your sperm DNA fragmentation, but there's a much easier way. Just have them ejaculate twice, one time 3 hours before the actual sample you're going to use, and then the second sample obviously 3 hours after the first. That second sample has much less sperm DNA fragmentation. We've been doing that with great results. You can also use, as long as the sperm is good enough, you can use Zymo. It's a device which will screen it out. And that can get rid of 90% of the sperm with high DNA fragmentation. Obviously, you need a good embryologist who knows how to choose good sperm. I was just telling my embryologist today that she should publish our results. We're getting over 90% of our embryos to become blastocysts. I've never seen that before. I've never even read of that before. So between what we're doing to get you ready and what she's doing in the lab, then you can definitely do a good job. And I should say our lab director / embryologist, because she's our lab director. So Dr. Khosravi is like the best I've seen. She's incredible. And so you need to make sure you're working with a group that knows what they're doing with the sperm. There are also things you can do ahead of time. It takes about 3 months to maximize the sperm quality. So no smoking, no drinking, no drug use. And when I say no, I mean none, zero. You can't smoke anything. You can't have hookah. You can't have a little cigarette here or there. I just had one when I was out with friends, like zero. No alcohol, no marijuana, no drug use. Keep your weight down. Make sure that you're eating a healthy diet, preferably the Mediterranean diet. Loads of vitamins, and I mean loads of vitamins. So you want to make sure that you are taking fertility vitamins. We use the YAD products or ProFertile. They're both excellent. You can use any other one. I don't believe in brand pushing or anything like that, but those are the ones we use just because they're good and they're available. You want to make sure that you are ejaculating every 2 days. You want to keep your testicles cool, so don't wear anything tight. Wear boxers, not briefs, and make sure that you are using frozen peas or something cold that you put up against the testicle to keep them cool. Additionally, there are other things you can do, like investigate with ultrasound, make sure you don't have a varicocele. Some people need their genetics tested. Watch your diet, make sure it's low in cholesterol, low in sugar. All of these things will contribute to improving your sperm DNA fragmentation and are critical to getting better quality sperm.
I'm on day 7 of IVF cycle. Letrozole 4 pills per day for 5 days. Gonal F 200, Menopur 75. What do you think of this protocol?
It sounds like a low responder protocol. I've never seen one with 10 milligrams of letrozole. I mean, I'm sure it's fine. It's kind of odd that you're taking 10 milligrams of letrozole and then only 275 of Gonal F and Menopur total. And I will say that you should be balancing your Gonal F and Menopur. So we have talked about a British study before, which shows that having a half-half ratio improves the euploidy of your embryos to get you more euploid embryos. So I would definitely recommend that you consider that. So that would be more like 137.5, 137.5 of each. It's a little hard to do that with Menopur just because it's not a pen. You got to actually adjust the dose by pulling up the right amount in the syringe, but it's possible. Or at least get close to that, and that'll give you a better result.
Does multiple IVF cycles increase the risk of cancer?
No, we actually reviewed that. How long ago was that?
That's so recent, I thought.
That was. It was like 2 months ago, two and a half months ago, guys. We had a review of whether or not IVF increases your chances of cancer. We should probably re-advertise that one. Yeah, so no, it absolutely does not increase your chances of cancer at all. Doing IVF has no impact on your chances of cancer. That's being looked at in so many studies I've lost track, but the latest one was huge. It was a big meta-analysis. I think it was an Australian study, and it was very well done. No increase in risk, so you're safe. Yeah.
Do you recommend to use prednisone to reduce the levels of natural killer cells when PCOS is the case?
Oh, that's a really interesting question. So there are some studies that have looked at outcomes of PCOS patients using steroids. I'm not aware that they've specifically looked for the natural killer cells, but there is a benefit. Whether it's mediated through a hormonal route or it's mediated through a immunological route, I don't know. That's a great question. I'll have to look that up. But the reality is that the studies have supported using dexamethasone for PCOS patients when they're going through fertility treatment because it yields a higher success rate. So yes, I would suggest using it. If it's specific to your natural killer cells, it's going to be even more beneficial. So yeah, sure. Although that can sometimes take an even bigger approach, requiring things like intralipids or IVIG or subcutaneous IG, sometimes even stronger medications. So the biologics like Humira and so on. So depending on how strong your immune reaction is or immunogenicity is, it'll depend on what we do for you.
For my first FET, I was on 50 milligrams of PIO every second day. 4 months later, for my second FET, my clinic has switched to PIO, same dose every third day.
Yeah.
Any idea why this was for all patients?
So there's a study by Shady Grove Fertility, which is a very big fertility center in the US, which compared daily to once every 3 days, and they had the same result. So they said it's fine to go to once every 3 days. I don't love that idea because the way that this works is your progesterone kind of goes up and down and up and down. And I always feel that pregnancy very much likes one kind of uniform, constant homeostasis approach to things. So we just use it every day. Is it painful? Yes. Does it totally suck? Absolutely. Is it horribly unfair to women? Totally unfair to women. And I'm sorry to each and every one of you that we are doing this to, but it's what we need to do. If there was a better way, I would use it. Maybe if the Dufaston becomes available or someone runs a study showing that oral prometrium with vaginal is the same as the progesterone in oil with the vaginal, I would switch. But until I have that, I'm not switching yet. So we do it once every day. But there is a study out there. It was published probably, I want to say about two or 3 years ago, and they demonstrated that once a day was the same as once every 3 days for progesterone in oil. So that's probably why they switched. Yeah.
Would you recommend Emma, Alice, and ERA test
Nope.
if I have to fail?
No. So Emma and Alice makes absolutely no sense. If you're going to do that test, just do the Fertility testing, which is actually way more accurate and a much better test. Definitely not useful to do Emma or Alice. And as far as doing plus it requires a biopsy, and the Fertility test requires no biopsy, so one less pain. In terms of doing ERA test, never do the ERA test. It's useless, only if you have a thin lining. We were talking about that earlier in the show if you didn't catch it. The ERA test is useless. We have 3 videos on our YouTube channel about the ERA test, all of them reviewing either one, or the last one we actually reviewed, I think, 5 different studies. All 5 studies showed no benefit to doing the ERA test. Don't do the ERA test. It's a waste of time and money. That's not what's wrong with you. I can virtually guarantee you that. Huracan. Yeah, someone commented that we don't have a Lamborghini on the wall. So for those of you that are avid viewers, the blue car is a Huracan Performante, which I've seen once or twice in the flesh. Not in blue, I saw a white one. It is a gorgeous car. It's way out of my price range, but I hope one day to at least see one or sit in one again. So pretty cool car for sure. We have all the supercars represented. I just don't have a McLaren because I haven't found one that I liked yet. Yeah.
Yeah. Doctor, I want to start my conception journey.
Okay.
I have done all the necessary surgeries and tests in the past. I was told the IVF will be the best approach for me, but I was still trying to see if I could come naturally, but I don't see nothing happening. Where do I start from now?
You need to see a fertility specialist. I mean, obviously, I would need to know more about what's going on. I need to know why you haven't succeeded yet and what they found on your surgeries and why you had surgeries. So if you have endometriosis, IVF can definitely be beneficial, but not mandatory. So there are options available to you. Depends on your tubes, depends on how severe the endo was, your ovarian function, the sperm quality. So see a fertility specialist, make sure they're doing all of the right things to test you. Find someone that's good, not pushing straight into IVF, because any center you go to, and this is for everybody, anywhere you go to, if the first thing out of their mouth is you need IVF, run, because all those people care about is money. There is only 2 circumstances only in which IVF is mandatory. One is when your tubes are blocked. If your tubes are blocked, you have to do IVF. There is no question. There is no way around it. And the other one, still not mandatory, but borderline mandatory, is if you have very severe male factor or the sperm are non-motile. So if you have non-motile sperm or sperm with no tails or something like that, you have to do IVF. There is no way around that problem. But if you have any sperm, you can still do insemination. Now, granted, some inseminations are almost useless because they have a less than 1% chance of success, but there's still a chance. But realistically, that group where you have a very, very low chance with poor sperm, or the group where the tubes are blocked, those are the only 2 groups where IVF is mandatory. For everybody else, you should be presented with your options, given the risks and benefits of each option, given the costs of each option, and then be given a very in-depth look at what it's going to look like for you, how long is it going to take, what should your expectations be in terms of success rates, and then you make the decision that is right for you. If you're going somewhere where they go, you need IVF right off the top, you're going to the wrong place, because that's just wrong to say. In the vast majority of cases, I'd say probably over 95% of cases we offer patients options. And I think my patients trust me because of that, because I'm not pushing them into IVF just so we can make a little bit more. I'm always going to work with you to achieve your goal your way. And that's basically who you should always find, someone that's willing to do the same thing.
Is it still possible for implantation to occur after 12 DPIUIs? 12 DPIUI?
Days post-IUI. Is it possible for implantation to occur 12 days post-IUI? No. Not unless something went bizarrely wrong and you didn't actually release when you were supposed to and released much, much later, and then you're just implanting at that point. So generally speaking, the answer to that question would be no.
If I'm doing an unmonitored round of Clomid, should I also take progesterone with it to help with implantation?
I'm a believer in the progesterone. Some people would argue against it, but I believe in it. So my answer would be yes, but you must know when to take the progesterone, because too early and it's birth control, and too late and it's useless. So if you're taking Clomid, and I'm not sure why you're taking Clomid, but if you're taking Clomid for assistance with fertility, you need an ovulation predictor kit. When the predictor kit is positive, 2 days after the predictor kit is positive, you start your progesterone. So if you get the P stick and it shows today that you're positive, you would start your progesterone on Tuesday. Now, just quickly going back to why you're on Clomid. So if you're on Clomid for PCOS, you shouldn't be. You should be on letrozole, because in a head-to-head comparison, even Tarek knows this now, Clomid gives you a 19.1% success and letrozole gives you a 27.5% success. If you're on Clomid for unexplained infertility and you're only on Clomid, it's useless. It doesn't help you at all. Unexplained infertility has anywhere from about a 3.1 to 4.3% success rate. Clomid alone has a 3.8% success rate, so you're not helping yourself. So don't bother with that. That's not going to be beneficial. Clomid with IUI helps, because that gets you to 7.8 to 8 point something percent, but alone, just Clomid for unexplained, it's not of any value. The only other reason you'd be taking it is if you're trying to have twins. We never recommend that, so I'm a little concerned about why you're on Clomid. So either reach out to us and explain, or talk to your doctor, but nobody should be on Clomid these days unless they have a very good reason for it, like you failed letrozole or something.
You got 1 minute left, and I think I have a good question.
1 minute till 3.
1 minute till 3.
Okay.
1 till 3?
I don't know, whatever you want, man.
I got a lot of questions, to be honest.
All right, there's a lot of questions.
Yeah, there's a lot of questions for some reason.
Should we do an extra 10 minutes for our first Euro edition? You got time?
Yeah, I got it.
Okay. All right. We'll give you an extra 10 minutes. Go for it.
Dinner at 8:30. Yeah. So anyway, well, here's an interesting one.
Yeah.
What is your opinion on an euploid 6BA embryo? Embryologist said it was fully hatched prior to biopsy. Will the embryo be at a higher risk of not surviving thaw?
Yeah, so we actually reviewed that as well. It's great how we actually cover we are ahead of the game. We cover everything on this show. So about a month ago, we did a video also on YouTube about predicting success, like which factors predict the success of your FET. So if your embryo is fully hatched when they freeze it, which obviously would have been the case if that's when they biopsied it, then it actually does decrease the chances of success a little bit. Fully hatched embryos don't love being frozen. So you kind of want them when they're a grade 4 or a 5. A 6, which is a fully hatched embryo, is not ideal for freezing. They actually had a lower chance of success when they were going into freezing. It was better when they thawed and they were fully hatched. Then your chances increase, but to survive the thaw, it's a little bit lower. So yeah, having said that, that sounds like a very good embryo, so hopefully it'll survive the thaw and then you're good.
You answered this, but I guess just to make sure they were listening. What is the correct spelling of fertility?
Oh.
My doctor wants to look into it for me.
Can
and
you
did the correct spelling?
Can you type it in there?
Yeah, I can type it.
Or give them the link?
I can
We'll
type
put it up for you. It's www.f like Foxtrot, E like Echo, R like Romeo, T like Tango, I like India, L like Lima, Y like Yankee, S like Sierra, I like India, S like Sierra.com.
And it's been shared.
Perfect. And it's being shared, so you guys can all see it up there. It should be on the screen or messaged out to you guys.
Yeah, so hi Dr. Victory. How do you know when a patient has been overly suppressed by birth control? I have a low AMH of 0.99 and I'm 37.
So you can get overly suppressed. We're still unclear as to whether birth control suppression affects your AMH level. So I just take you off and recheck in a couple of months. If your LH is very low, you're probably suppressed. So that's the way to know if your birth control is suppressing you. If your LH and FSH are very, very low numbers, you're probably suppressed. Will it have an impact on your AMH? I don't know. You'd have to come off, wait a few months. Your ovaries should recover. We see what you're like.
I'm currently doing stims and had 10 follicles at baseline, but only 4 responded.
Oh.
I was on birth control from February 26th to April 21st, waiting to start my cycle. Would this cause ovaries to respond slowly?
It can. Again, if your LH was really low at the beginning, yes, it can. So for our patients, if they're poor responders, if they're older, we don't use birth control anymore. We only use it for the ones that are either strong ovaries or younger. And it has to be both of those. You got to be young and have strong ovaries. If you're young and you have weaker ovaries, again, I wouldn't use birth control because you can get suppression, and when you get suppression, it inhibits the responsiveness of the ovaries. You can overcome that if you're doing duostim, because the rest of the follicles will perk up and grow later. As long as you find a center that A, does duostim, I'm kind of shocked by how many centers don't, and B, knows how to do it, most again don't, and C, is willing to not charge you an arm and a leg. So our duostim program is discounted because in that second cycle, we recognize this is for patients that aren't doing great to begin with, so we drop the price quite a bit. It's 37% less in the second cycle than in the first. But you know, not everybody's doing that. Some places will just charge you 2 full IVF cycles. So you're certainly better off going into the first cycle with no suppression.
Do you need a prescription for estrogen and oil? What is your recommendations for oral and vaginal progesterone at 6 weeks pregnant? Thank you.
For estrogen and oil? Okay, I've never even heard of estrogen and oil. I think you mean progesterone. You do need a prescription for progesterone and oil. We continue our patients till 12 weeks. Most places stop after 6. So our protocol is a bit different, but I don't like messing with things. Like I said earlier, I like homeostasis, neutral, balance, control, no big changes in pregnancy. The placenta takes over the role of producing those hormones by the time you're at 12 weeks fully. So I don't like changing it till it's fully taken over.
Hi, listening in from the UK.
Hello, UK. My daughter's in the UK. Hi, Jenna. I hope you're still watching, stinker. Yeah.
I have been diagnosed with compound heterozygous MTHFR.
Yep.
Can you recommend a methylfolate vitamin safe for pre-pregnancy and during pregnancy? I cannot absorb folate.
Yeah, so folinic acid should be okay. That's the one you use when you have MTHFR. And you should be on aspirin and heparin because your clotting risk is higher as well. And that probably has more of an effect than the folinic acid actually does. So that's what we recommend.
Is progesterone via pills like Dupaston in combination with vaginal like Uterogestan most advisable above oil injection in combination with vaginal?
So there is no head-to-head trial that I am aware of comparing oral and vaginal to oil and vaginal. We are big fans of the oil and vaginal because it works for us and our success rates are insanely high. But I don't know. The actual success rate in this study, just to go back, you know, keep in mind this is from Vietnam, so I don't know that their success rates are quite the same as ours. So let's look at the live birth data. So it was pretty reasonable. It was 56.5% in the both group. So that's pretty good versus 43.5 in the single group. So I mean, 56, we're definitely getting higher than that, but most people would be very happy if they had an almost 60% live birth rate. So that's a pretty reasonable success rate, guys. So you could probably do the oral and the vaginal, or you could do the oil and the vaginal. We don't know head to head. There's no comparison out there for me to tell you one is the same or better or worse. I can't answer that.
If I ovulated on Clomid 50 this month but didn't get pregnant, should I bump up the dose to 100 milligrams next month?
No. If you ovulated, you don't need a higher dose. Granted, we always use 100 just because I like efficiency and I don't like it when you have to try multiple times. So we just start at 100. Same thing with letrozole. Excuse me, we start at 5 instead of 2.5. But if you're ovulating on the 50, you don't need 100.
I'm on my 3rd round of letrozole. I was due for my first period, first week of April. Does that mean letrozole is not working? I took a test a couple weeks ago, was negative. Could I also be pregnant?
Well, you should always check for pregnancy if you're not having a period. So on our website, if you go to drvictory.com and you go to the resource tab, can you share that? Is that doable if you do the share thing?
No, not right now.
No? Okay. So on our website, if you go to drvictory.com, and we'll put up the link, and you go to the resources tab, you'll see a flow chart for what to do when you're taking letrozole. So the idea is you have to start a period, often with progesterone if you're PCO, and then you take the letrozole from day 3 to 5 of your cycle, and then you wait until 35 days from the first day of that period, okay? So if at 35 days you have not had a period, you're either pregnant or it didn't work. So meaning the letrozole just isn't making you release your egg at that dose. So if you're past 35 days, you've not had a period yet, you do a pregnancy test. Pregnancy test is negative, you take the progesterone again, and then you take a higher dose of letrozole the next cycle that starts on cycle day 3. If you're pregnant, hallelujah. If you get your period within 35 days, it likely means that the letrozole is working, you just didn't get pregnant, so take the same dose. So follow our flow chart. It's on the website. It's done in graphics by Jenna. You've got it there?
The link's right here.
The link's right there, so just follow that and it'll take you there. You'll be able to see what to do. Just go to our website. And check out all our awesome information there too. Yeah. 1 or 2 more?
Yeah, sure. I just completed a FET transfer with a day 5 embryo that is healthy. I am impatiently took an at-home pregnancy test yesterday that sadly was negative. What are the chances for a positive?
How many days out is she? Does it say?
Test? No, day 5 embryo that is healthy.
Well, it depends on how far out you are from the test. If you're under 8 days, there's no way it's going to show up positive. If you're 11 days with a really good test, you might. You really have to wait till you're like 14 days for the urine kits to be pretty accurate. So it all depends on how far out you are. If you're negative with a blood test at day 14, you're negative. It's not going to turn positive, unfortunately.
Does ICI work with Femera for unexplained secondary infertility, normal sperm count?
No. In fact, ICI never works. So intracervical insemination is useless. They've got lots of studies which show there's no benefit to doing ICI, especially if you have unexplained infertility. You need to do IUI with Femera. It can't be ICI with Femera. There's no evidence that that's useful. No one does ICI. The only patients that can do ICI, and it's kind of reasonable, is when women want to use sperm from someone that they know or have been given sperm from, but don't want to have sex. So they just load it into a turkey baster and they fire it into the vagina. That's basically ICI for all intents and purposes. Intrauterine insemination, the catheter is actually going in the uterus and we're inseminating you in there, plus we prepare the sperm. So the sperm's faster, it's healthier, we're getting rid of some of the bad ones, we're improving the quality of the sperm and so on. Last question.
Yeah.
Last question. Make it a good one.
I got one.
It's Tarek's pick.
Yeah, this is
You gotta make like something that comes up and goes Tarek's pick.
Oh, okay. I'm with that. We can do that.
Yeah.
Hi, Dr. Ricky. Thanks for the Europe-friendly timing. I did an IVF cycle in February, which achieved our best results.
Oh, great.
15 eggs retrieved, 12 mature, achieving 6 blasts.
Awesome.
We decided to do a second round, repeating exactly the same protocol to bank more embryos.
Yeah.
This time we got 13 eggs, but a complete surprise with only 5 mature and 2 made it to blasts. My doctor cannot explain the difference in egg maturity. The first cycle was 35H45 between trigger, overthrow, and retrieval. Second was 35-15. Can 30 minutes make such a difference, or what else could impact egg maturity with identical protocols?
It can make a difference. It's certainly possible that there's a little bit of a difference there in terms of your egg maturity, but the bottom line is that you're probably going to get you're probably still going to get a good outcome either way. I think we're off camera now, right?
Yeah, this one.
Yeah, we're off camera, so you guys can probably hear me but not see me. We ran out of memory. So bottom line is, waiting a little bit longer would be beneficial, but I think it has a lot more to do with how large your follicles are than whether or not you're getting triggered and retrieved at the right time. 30 minutes should not make a big difference. Here's the easiest way to find out. If your follicles were late M1, then yeah, it may have been that brief delay or going earlier. But if your follicles were like GV, then they just triggered you too early. Okay, guys, we're going to call it quits for now. Thank you for our Euro edition of Fertility Factor Fiction. We will try and do this maybe once a month. We'll look at the stats and see how we did. And it was great to have you guys. Thank you from all the European countries for joining us. Hope you enjoyed our show. Make sure you subscribe to our YouTube channel and to our Instagram. Follow us there as well. We've always got new information going every day, or at least several times a week. And our videos all go on our YouTube channel, so check us out. And if you need some motivation, I just started a new exercise regimen, so follow me on Instagram for that, and we will post me dying slowly doing Focus T25. Have a great day, guys. Stay safe and wear your masks, hand sanitize, be careful, and above all, please get vaccinated. It's not going to impact anything. Get vaccinated, get vaccinated, get vaccinated. Take care, guys. Have a